Okay, so we now are going to talk about drugs to deal with these problems, okay? And then an antimicrobial drug refers to any drug that is used to treat any microorganism. So it's an all-inclusive term, okay? Whether it's a virus or a fungus or a protozoan or whatever. An antimicrobial therapy means any drug to be used on to prevent infection from any microorganism. And then subcategory to that is an antibiotic. And strictly speaking, so antibiotics, our first antibiotics that we discovered were actually compounds that were produced by certain organisms to prevent infection by other organisms. Okay? And so actually penicillin is the first antibiotic ever produced, and it was mold that we isolated penicillin from. So penicillin, so mold is a living thing that wants to live too, and it has a problem of bacterial infections as well. We have a lot in common with mold. And mold was ahead of us on this curve. It was producing a substance called penicillin that would protect itself from bacteria. And so somebody left a sandwich out overnight or something. I don't know the story, but they isolated penicillin, and then they found that it could be used to treat human infections as well. So a lot of antibiotics are actually isolated from natural sources, and then we also have antibiotics that we've commercially developed. Okay? And then these antibiotics have two ways that they deal with these bacteria. There are some that what we call bactericidal, which means that they actually kill bacteria. And as you can imagine, that those are the most effective at completely clearing an infection. We also have drugs that are what we call bacteriostatic, which means that they don't kill bacteria, but they greatly slow down the growth and division. Okay? And so bacteriostatic drugs are rarely used by themselves, but they can be combined frequently with bactericidal drugs to have even better efficacy. Okay. So there's lots of ways of categorizing antimicrobial drugs. Okay? And there's two ways that I'd like to introduce to you. So this is like trying to understand the family tree of these microbial drugs, antimicrobial drugs. One classification scheme is by susceptible organism. Okay? What groups of organisms are susceptible to what antibiotics? The other classification scheme is based on mechanism of action of the drug. So I'm going to show you what both classifications look like. So by susceptible organism, what we see first is the first label here is antibacterial drugs. Right, so everything on this slide, every drug on this slide is an antibacterial drug. Then we have the subcategory of narrow spectrum versus broad spectrum. Okay? And then we have further categories based on shape of the bacteria and whether it's gram-positive or gram-negative. So we've got, if you notice, the penicillins are listed under gram-positive cocci, gram-positive bacilli. Okay? There's many penicillins under the broad spectrum category of gram-positive cocci, and even some gram-negative bacilli. We've got gram-negative bacteria, and the term aerobe means that they require oxygen to live. Okay? And those gram-negative organisms that require oxygen to live will frequently infect things like the respiratory tract or the ENT, thank you, ear, nose, and throat, right? Ear, nose, and throat, skin, right? They have access to oxygen, basically. The anaerobic gram-negatives tend to be found in the GI tract, okay? Where there's not, they don't have, in the center of the GI tract, there's not a whole lot of oxygen there for them to, but that's okay. They're anaerobic, so they don't need it. So we've got drugs that, the class of drugs under that category, the aminoglycosides, the cephalosporins, okay? And then we've got one category unto its own, which is the mycobacterium behind tuberculosis, and there's a group of drugs under that. All right? Now, these classes don't mean anything yet because we haven't discussed them. We also have a group of antiviral drugs. Antiviral drugs treat viral infections. So there's a whole list of drugs that treat HIV. Okay? There are drugs that are used to treat influenza, drugs that are used to treat other viral infections. Okay? We're not really going to discuss too much any of the antiviral drugs. Okay? We'll discuss especially the HIV drugs in patho, but just in terms of their mechanism and usage. Okay? And then the antifungal drugs are used to treat fungal infections. We don't go too much into them as well. So most of what we're going to study are the antibacterial drugs. So if we look at just the antibacterial drugs, this is what it looks like to categorize them by mechanism. Okay? What do they do to the bacteria they encounter? So there are drugs that are inhibitors of cell wall synthesis. Okay? They block cell wall synthesis and are generally bactericidal. If you block the synthesis, you kill the bacteria. That includes the penicillins. It includes the cephalosporins, right? It includes impenem, vancomycin, caspofungin. Okay. Drugs that disrupt the cell membrane. So not the cell wall, but the cell membrane. Right? Amphotericin B, daptomycin, itraconazole. Bactericidal inhibitors of protein synthesis. So what they do is actually block protein synthesis and the proteins that the cell needs to survive, and it kills them that way. Those are the aminoglycosides. Bacteriostatic inhibitors of protein synthesis. They block protein synthesis, and it blocks the proteins that are used for growth, and so it slows down bacterial growth. Doesn't kill them. That's clindamycin, erythromycin, linezolid, tetracyclines. Drugs that interfere with the synthesis or integrity of bacterial DNA or RNA. Okay? These are genome disruptors. Fluoroquinolones, metronidazole, rifampin. Okay. And anti-metabolics, these are drugs that disrupt elements that are needed for metabolism. Okay. Sulfonamides, trimethoprim, flucystine, yes. Okay. And then I'm not going to get into the antiviral drugs, but you can see the antiviral drugs also have different ways that they operate. Yes, ma'am. Just in terms of the fact that they exist, but no. Correct. The fact that they exist, and they do. Yes, ma'am. Say that again. We'll talk about the ones that, yeah, we'll go through it. So we're going to talk first about the penicillins. And the penicillins are drugs that weaken the bacterial cell wall. That's the common method of action. And they are active against a wide variety of bacteria, and they actually tend to have fairly low toxicity. Penicillin's a great drug. Okay? There's only really one major downside, and that's that of all the drugs that humanity uses, there are more cases of anaphylactic reactions to penicillin than probably any other drug. Okay? There's a high rate of allergenicity when it comes to penicillins. And not all of that allergenicity is anaphylactic, right? But we do see it. So principal adverse reaction are allergic reactions. Sometimes you see penicillin reactions, allergic reactions in children, and they outgrow it. Okay, that's actually fairly common. But there are, unfortunately, lots of allergic reactions. The structure includes a beta-lactam ring. So penicillin is part of that beta-lactam family. Okay? And other beta-lactam drugs include cephalosporins, aztreonam, imipenem, meropenem, and etrapenem. And you can tell that the NMs, we'll talk more about those drugs. But there's a large group of beta-lactam antibiotics. Yeah. Does it run in families? So does penicillin anaphylaxis run in families? I would assume so. I don't know for sure, but I would assume that when you have really strong allergic reactions like that there's probably a pretty strong genetic basis. Yeah. 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 If there's any family history, so there you go. And if you have anaphylaxis to penicillins, it also knocks out a lot of other antibiotics. You may also have cross allergenicity to other beta-lactams. So we don't really give up on antibiotics easily, but certainly if there's anaphylaxis is a real concern. So the beta-lactam structure is that box that's drawn in the chemical structure of these drugs. So notice that penicillins, cephalosporins, monobactams, carbapenems, they all contain that box structure, right, that beta-lactam ring. And so because of that, they're all susceptible to that beta-lactamase enzyme that some bacteria have developed. Okay. So just to make you aware of that. And then just to flesh that out a little bit more, the beta-lactam antibiotics, not every drug name that's under each category you're responsible for, just to not let you panic. But the penicillins, you see the cephalosporins. So the last slide I had penicillin, cephalosporins, carbapenems, and monobactams. And if you notice the cephalosporins, there's actually about 4 or 5 generations of cephalosporins. Okay? And they differ a little bit, but these are all highly related. These are all beta-lactam antibiotics, so they're relatively related in several ways, which also means that there's potential for cross-allergenicity. Okay? It's not a given, right? But there is potential for cross-allergenicity as well. Okay, so if we look at the penicillins, what we see are we've got narrow-spectrum penicillins, penicillin G and penicillin B, G and V. Okay? So not only are there beta-lactamase enzymes that bacteria can use, but bacteria also can produce something called penicillinase, which can break down penicillin. So penicillin G and penicillin V is really, can be considered first-generation penicillins. And unfortunately, they are sensitive to penicillinase. So, no. The bacteria makes it. Yeah, the bacteria makes the penicillinase, and then the penicillin doesn't work if it makes that. Okay. And so the conditions that it can treat: streptococci, Neisseria species, many of the anaerobes, and the spirochetes, right? So syphilis and Lyme disease. But if you've got an infection that you're treating with penicillin, right, and it's an organism that should be sensitive to penicillin, and the penicillin's not working, it could be that this is a penicillinase-producing infection. And so you need to switch to potentially a different penicillin. Okay. There are still narrow-spectrum penicillins, nafcillin, oxacillin, dicloxacillin, and these are penicillin-resistant. Okay. Excuse me, penicillinase-resistant. They're penicillinase-resistant. So you've got the person with, this happened to me actually. I had my wisdom teeth pulled, and I got dry socket. Anybody got, yeah. Oh, it's terrible. It's bad. And they plug you with that clove stuff, and you just smell and taste clove for like a week. But I got this horrible infection in my socket when they pulled out my wisdom teeth. And they put me on Penicillin G. And then my fever spiked to like 104 or something like that. It did not work. And then I had to like drag myself to CVS again. And they gave me one of these narrow spectrum penicillins. Okay? And that's generally the goal when you're treating an infection, is if one doesn't work, you go one step up. Right? Don't skip steps. You don't have to go to a broad spectrum. What you want to do is maybe, let's try a penicillinase-resistant penicillin. Okay? And that worked. And so these narrow-spectrum penicillins that are penicillinase-resistant are frequently go-to drugs, first-line drugs for Staph aureus infections, okay? Which are a common cause of these. When you have something like a tooth pulled and it gets infected, it's likely Staph aureus that's infected it. Okay? And then the next step in terms of these penicillins is a broad spectrum. And the broad spectrum penicillins include ampicillin, amoxicillin. Okay? And so you can recognize amoxicillin frequently if you have any kind of head, nose, and throat infection or ear infection. Amoxicillin is frequently the first drug tried. Okay? And part of that is because it's the most likely to actually work, and you don't need a secondary visit. Okay? And so there are lots of organisms that are frequently treated with these broad-spectrum penicillins. And then you have something called extended spectrum penicillins. So they're broad spectrum, but then their spectrum has actually been broadened even further. Okay? So not only can they be used to treat any of the organisms in the broad spectrum, they can also be used to treat things like Pseudomonas aeruginosa, otherwise known as what causes hot tub rash. Right? Gross. So gross. So gross. Enterobacterius, bacterial species mean GI bugs, okay, and others. So these organisms that are not normally sensitive to the extended, to the broad spectrum penicillins, the extended penicillins can cover them. Okay, so that's like ticaracillin, piperacillin. Okay. So bacterial resistance to penicillins, I've mentioned this. So inactivation of penicillins by bacterial enzymes, penicillinase and beta-lactamase. Okay? Any organism that can produce beta-lactamase can be resistant to penicillin, and then the ones that produce penicillinase are going to be resistant to the penicillin G&V. Okay. And then we also see another mechanism, common mechanism of resistance, and that's production of what we call altered penicillin binding proteins. So the proteins that usually bind the bacterial proteins that penicillin usually binds to, some bacteria have altered their structure, and that has allowed them to escape all of those penicillins. And one important example is MRSA, or methicillin-resistant Staph aureus. Staph aureus is an incredibly common bacterial infection. Okay? And most Staph aureus are going to be sensitive to the penicillins. But methicillin is one of these very broad spectrum penicillins. And so when you have a staph infection that is resistant to that, it's likely because they've created those altered binding proteins. And those organisms are called MRSA. Okay? And MRSA, there are drugs of choice to deal with MRSA. Okay? One example is vancomycin. Vancomycin is a very strong antibiotic. Okay? And there are others as well, but that's how MRSA escapes. Yes. That's exactly what it is. Yes. Target site alteration. Exactly. Okay. So let's talk a little bit more about penicillin G, our good old friend. It's bactericidal to numerous gram-positive and some gram-negative organisms. There's lots of prophylactic applications. It can prevent syphilis in an uninfected partner whose other partner is infected. It also is used to treat syphilis infection. It can be used to prevent recurrent rheumatic fever and also used to prevent bacterial endocarditis. Okay? Bacterial endocarditis is a complication of certain bacterial infections, where the infection starts one place and it gets into the endocardium. Okay? And so giving penicillin G can prevent that from happening. It's the least toxic of all antibiotics, but it's the most common. Penicillins are the most common cause of drug allergy. Penicillin allergies. For the non-anaphylactic reactions, you can have immediate reactions. So that's within 2 to 30 minutes of taking your first dose of penicillin. You can have what's called accelerated reactions that can happen within 1 to 72 hours, so within the first couple days. And then you can actually have delayed penicillin reactions. And this is probably the hardest to identify because the reaction happens basically around the time where the course of penicillin has ended. So it's still related to the penicillin administration, but the mechanism for developing the reaction takes a long time. Okay? And so it doesn't manifest until several days or even a week after you've started it. And frequently it's like a day after you discontinue it. Now the anaphylactic reactions are very similar to other anaphylactic reactions you'll ever see. And so the most worrisome parts of the reaction include laryngeal edema, so swelling of the throat, compromising airway, bronchoconstriction, and severe hypotension. Okay? And so obviously epinephrine is going to be an important treatment. So drug interactions, and for the first two, for the first one, it's a positive interaction. Okay? The first interaction is a beneficial interaction. So aminoglycosides are often used together with penicillin. And so what happens is the penicillin weakens the cell wall, and it allows the aminoglycosides to enter the cell more readily. Okay? So aminoglycosides can enter the cell more easily once penicillin has weakened it. Now, the catch with using aminoglycosides and penicillins is that you don't want to mix the two drugs or give them at the exact same time. Okay? So you want to both physically separate the administration and separate it with time. Okay. So that's the story of the penicillins and aminoglycosides. Now, one interaction that you want to avoid is using bacteriostatic drugs with penicillins, because bacteriostatic drugs slow down growth and division, and penicillins are most effective at actively growing bacteria. Okay. So combining the penicillin with a bacteriostatic drug reduces the efficacy of penicillin. And lastly, there is a drug, probenecid, and I think that that's an acid reducer, pretty sure, will actually delay the renal excretion of penicillin. So it'll actually make blood doses of penicillin to be increased, okay, because it slows down the excretion. Yes. No. Exactly. There's very little concern when penicillin levels rise. Just knowing that that's happening. Yeah. Yeah. Okay. So the Penicillinase-Resistant Penicillins, okay, the ones that are available in the United States, nafcillin, oxacillin, dicloxacillin, they are useful to treat all the organisms that penicillin can treat, but they are resistant to the enzyme penicillinase. Okay, so they are a step up from Penicillin G&V. Okay, and they are widely used to treat staph infections. The broad-spectrum penicillins, ampicillin, amoxicillin, extremely common, widely used. It has the same spectrum as penicillin G, but it has increased activity against some of the gram-negative bacilli. Okay. And some of the adverse reactions include rash and diarrhea. And then the extended spectrum penicillins, so the spectrum is even broader or even wider than the broad spectrum. The anti-pseudomonal penicillins include ticaricillin, piperacillin. Okay. So they have a broader spectrum, but they are penicillinase sensitive. Okay. So that's definitely something to keep in mind. But the thing to remember is that those broader spectrum, those organisms like the pseudomonal organisms, are not as likely to be producing penicillinase. Okay. So the fact that they're basically more effective than you might think, even though they're penicillinase sensitive. Okay. So it is these drugs are used widely, and they are used primarily for infections with that Pseudomonas aeruginosa, which, in addition to being the hot tub rash organism, it's also a frequent organism in immunocompromised patients. So those are drugs of choice for those patients. Now, you first, yes. I'm not sure. Actually, that reminds me, I have an answer for your question about naproxen. So naproxen is first generation, and it, like ibuprofen, is non-selective. COX-1, COX-2. Yes. And so the only second generation drug that we talked about is, celecoxib. Exactly. Okay. I'll make that more clear in the review session. But yes, ma'am. Because those are not organisms where penicillins are really the first choice drug. So they're not going to really be exposed to as much penicillin as the organisms that, yeah. You're welcome. Okay. So the miracle of science and chemistry, these drug makers realized that we could take one of these penicillins and enhance the efficacy by adding something to it that would prevent some of these resistant strategies. Okay? And so one of it is by adding what's called a beta-lactamase inhibitor. Okay? Remember, beta-lactamase is the enzyme that the bacteria produces to digest the drug. Okay? And so a beta-lactamase inhibitor would block that and increase the life of the drug, okay, and activity of the drug. So the three substances that are frequently added, the three beta-lactamase inhibitors, are clavulanic acid, tazobactam, and sulbactam. And probably the most well-known one of these combinations is augmentin, right, which is amoxicillin and clavulanic acid. We also see unicin, which is ampicillin and sulbactam, timentin, which is ticaricillin and clavulanic acid, and zosyn, which is piperacillin and tazobactam. And so again, if someone has got one of these ear, nose, and throat infections, and they're given amoxicillin and it's not working, the most likely next step is to give augmentin, which has amoxicillin and clavulanic acid. Okay? We don't jump away from the beta-lactams. When something is not working, we tend to go up stepwise. Okay?